hair transplantation. Let me just, and also, I should say also thank you to Maria Vitale, because she nicely lent me, or I borrowed from her this computer, because I sent the presentation to Omics in advance as they asked me, but they are in the middle of nowhere. I don't know where they are. So I have to put my pen drive and look for a PC and so on. Anyway, first of all, I want to tell you a little bit about Svensson in Europe. There is Svensson in Asia, I believe, and there is Svensson in Latin America, I believe so. Svensson in Europe is, you have a point, light pointer? Thank you, sir.
Hey, Frank, where's that laser pointer?
The laser pointer, if you think, thank you very much. Okay. Okay. First of all, let's say that even there's Svensson in Europe, in Spain, Portugal, Germany, and Switzerland. The headquarters are in Madrid, and what I think is interest for you, even you are in the hair care as the hair transplant surgeons are here with a lot of experience. I'm not going to talk about hair transplantation, about acute telogen effluvium. Telogen effluvium is very important, as you will see, mostly in women, because means, well, I will explain that, but my take-to-home, you say take-to-home message for you in different areas is that I have been 4 years in the world of hair care, but up to 20 years in the world of clinical research in different areas. And what I would like to do in this presentation for you is to learn some concepts. You may have learned, sorry if I'm, obvious in saying these things, but that gives you advantage to provide information to the scientific medical world. If you have enough patients, that's the first thing. This is about 500 patients. It's a retrospective we look into because we have a centralized intranet in Madrid about all of the centers of Spain. So all the information about the hair care patients of these 39 centers you can get into and analyze, and you will see. But also the other thing is give you a little bit about methodology, to be more critical about when you say, I don't mean about the presentations you gave, which are prospective, but when you do retrospective, you can confuse things, and then that I think could be my modest contribution to this presentation. Anyway, go ahead and hopefully be in time of, please let me know when I'm running out of time. So, acute telogen effluvium. Why we call this acute, and then we call chronic? Forget about logistic regression. Don't be worried about what is this guy is going to tell you. Logistic and regression. Okay, it is I think it's a easy concept to explain if you know what it is. But acute telogen effluvium is, telogen effluvium is, about the phase of the follicle is anagen, is producing the hair, then the catagen, and telogen is fall out the old hair because another one is starting to the anagen. This process is correct me if I'm wrong, but it is in a regular scalp, 100 times a day. The hair falls because another new hair is coming. When you say telogen effluvium, and the ratio is usually 8 to 1. 8 to 1. When you say telogen effluvium, it means that the more that it is 3 to 1 or something. Much more number of hair is in this phase, and it's been replaced. But for women particularly, which are the patients who have most acute telogen or chronic telogen effluvium, is the hair loss is really stressful, and and as you have seen, maybe devastating if gets to the point of chronic telogen effluvium. Why? When you say acute telogen effluvium, acute it's a clinical concept. It's, a woman has, a birth, is after birth, or it has, a medication, a severe disease, a number of triggering causes, who starts or just the fall season is coming, so the telogen effluvium starts, and then it goes like the season, a seasonal, track. The main thing when you say acute is that it's a clinical concept that say after 1 year or between 6 months and 1 year, particularly if you remove the cause, if it's a thyroid disease and you remove the thyroid disease, the telogen effluvium stops. And you say acute if it stops earlier than 1 year. Why this difference of, and say chronic and telogen? It's not, trivial. It's important. Well, I told you about this. 90% are in anagen, 10 in telogen, 100 hairs. But if you cut a telogen effluvium, then the ratio could be this, and shedding more than 300 hairs. But why is the difference to say acute and chronic? It's very important. This is the answer. This is speaking about male androgenetic alopecia, but can be also female androgenetic alopecia, which now we are talking about the atrophy of the follicles, and then they are candidates for the hair transplants or whatever, if you don't work good enough for them. But for the women also, it's called now female hair pattern loss, because it is not very clear if it's androgen related, but usually mostly it's postmenopausal. But you have a premenopausal women having a chronic, meaning more than 1 year of effluvium telogen. Everybody knows it is highly associated, or more likely associated even in premenopausal women, to this kind of androgenic related alopecia. And that's for women is also, much more distressing than for men. So, which were our, you see here, this is, the pattern we call female pattern hair loss on a patient. This is progressive, it's not starting in 2 days, but it's very well known from years that it is associated when they have chronic, meaning more than 1 year of telogen effluvium, they can start having this even before the menopausia. So, the aim of our study, I told you about the points in blue, focus in the points in red, is to identify predictive clinical factors of why people, even after removing the cause, or women, go to progression of chronic, meaning have more than 1 year and then are in risk of female pattern hair loss, of androgenic alopecia, even before the menopausia, and to identify if acute telogen effluvium, meaning if you can predict before go to the chronic, you are going to be at a higher risk of that disease. That's the main objectives, the two main objectives. Prediction, help the trichologists and the dermatologists to say, okay, you have an acute telogen effluvium, but you have to be much more careful, not you, me as a doctor, to treat you more intensively or more than another kind of people. There are subpopulations, or every acute telogen effluvium is the same. What I want to show you now is not the same. What is the reason I will show you. So, what we have done is to analyze 500 patients from the intranet information, which is more clinical than other thing, but it's 500 patients. It's not that the number is, and we analyze a number of variables. Is important the age? Is important the year? I mean, if we are doing better as much as we progress as trichologists. The area of Spain, where Spain is very different, the north, the south, the center of Spain. There are a number of oral treatments which are not really having a good scientific support, like substitutes of amino acids and things like that. And minoxidil topical therapy, which usually is used for androgenic alopecia, it can have a value or not. And also, because we know that most of the patients, 70% of the patients usually, once you remove the cause, are cured. They don't have the pull test is called when you pull with from the hair, get more than 3, and that's pathologically as clinical dermatologists agree. The cause sometimes is removed, but we classify the cause in these 9 categories. Seasonal hair loss, which be, let's say, the more physiological. Severe diet, patients in not in a diet or in an anorexia. Postpartum, iron deficiency, any kind of iron deficiency. When we put here psycho-emotional stress, mostly is people under depression, antidepressive therapy, etc. Thyroid dysfunction, and most of them hypo rather than hyper. Medication intake or withdrawal is very well known that the patient is taking contraceptives, oral contraceptives. Once they quit, they can have for a number of months acute telogen effluvium. Anti-neoplastic therapies. This is not the fault when they put a strong, but sometimes they don't recover, or after a major surgery, women may have that. And more than one of the these are the categories. And this is important. This is going to be, I hope, so the message for you to bring home. So I told you, chronic effluvium, analyzing the data in our intranet was when the physician said is, the patients having shedding more than 1 year, and this diagnosis, as I showed you the pictures of the women, was also diagnosed by the physician. Now, this is univariate analysis and binary logistic. This is more for expertise in analyzing clinical data, but I hope I will explain you easily which is important of doing univariate or logistic, which is a multivariate. Let's go first with the univariate analysis. Univariate analysis is saying how many of the patients get cured means how many of the patients stop the shedding, are not going to the chronic more than 1 year. If we say they are not cured, it means that they went more than 1 year with telogen effluvium. The year they had it was not different. We didn't progress much in treating them. The average of patients cured was the same before 2010 than after 2011. And there was not a statistical difference. The area of Spain, you can see that Canary Island may benefit, but if you really want to be honest, analyzing is not a significant difference. So it means that this is just by random, by chance, or by not a reason. The age, it was different. When you just focus in the age of the patients not cured is higher than the age of the patients cured. But then you have to be a little bit autocritical in this, because sometimes you may excuse me, that's the problem of the univariate. You say, okay, the age is important, the older, the worse. And it may happen only that you have here all the hypothyroidism. And you're saying that is the age and is the hypothyroidism. Subpopulation is here. And it is said a confusing factor. So that's what you have to go to the multivariate analysis. So the age looks like it's different. These are the distribution of the causes, and then the triggering cause was not different by themselves to become chronic. It looks the same. The treatment didn't influence at all. And the minoxidil almost was better to treat with minoxidil than without treatment in this kind of patients. It was better. I have to run. Now, when we say about this, forget about the numbers. Forget about the numbers. Just forget about the numbers. When you say logistic regression, what we are saying is that we are analyzing if This is entered in a program and is capable of saying it's an independent factor of all of the others, or if it is just related with other factor. Okay, that's the logistic regression. We're saying yes or no. Is this independent or is dependent of other factors? Okay, so for the chronic, we didn't find really close to minoxidil use. But then let's go to the association with alopecia, with the female pattern, with the androgenic alopecia. Then we find a huge difference depending on which was the cause. The association with androgenic alopecia was higher in these three categories: severe diet, iron deficiency, and thyroid dysfunction. And you can say the same. Okay, you have here iron deficiency is worse because iron deficiency is also the older patients. So you have to analyze in a multivariate logistic regression analysis to see if this is independent or not. And that is a program, SPSS. You put the data. There is, you know, if you learn a little bit about how it works, it's not difficult. The age was not different in the association of androgenic alopecia, but here, then I would ask you, please just take a look at the numbers. The odds ratio means the risk of having associated androgenetic alopecia if the patient has a telogen effluvium compared with seasonal effluvium, which could be the more physiological. If you have telogen effluvium because of diet, severe diet or anorexia, you have 10 times of risk of iron deficiency and 16 times of risk if this is a thyroid dysfunction. What this is important is that these are independent of the other factors after the analysis. So the conclusions: triggering cause is an independent predictive factor of the association. You have to look at the triggering cause, and then you can say, if you are in this subpopulation of patients, severe diet, iron deficiency, or thyroid dysfunction, you have a higher risk as a woman to be on this kind of association with androgenic alopecia. Even at the beginning, before the acute telogen effluvium gets chronic or not, you can say that. So those patients can suffer in acute telogen effluvium, that's the take-to-home message, may benefit from different therapeutic approaches if you focus on the cause that induced even it is removed. And that's it. We were lucky to publish this in a prestigious journal, and I have to quote that because of the copyright rights. Let's say that dermatology therapy was accepted and also was awarded as a poster in the last World Congress of Hair Research last year in Korea. That's it. Thank you very much for your kindness.
Does anybody have any questions? Does anybody have any questions? Okay, before we break for posters, I would like to... Oh, I'm sorry, go ahead.
Yes.
Which is the characteristic that you observe in your study that really predict that this telogen effluvium is then androgenetic alopecia.
Yeah, that's clinical. I mean, it's a clinical diagnosis. Don't forget, we are speaking about an intranet who has the data of thousands of patients, 39 haircare centers in Spain. And I was lucky enough to get into. That's, you know, part of my job, but I'm grateful to Svensson to give me the chance to get inside of that as part of my job. I am also working as trichology in a clinic. But your question is clinical. Is in the chart of the patient, the doctor puts two diagnoses: acute telogen effluvium, and he looks at the pattern of the patient, and even is 32 or 44, he writes androgenetic alopecia.
But
It's
which percentage of people with telogen effluvium then is converted in androgenetic alopecia?
Which is the percentage of the total? It's not.
Approximately.
It's not the conversion. I had to look back. It depends on the. You mean as a total? I don't know exactly. It's a good point, but we were focusing in differentiate. No, it's.
Okay.
It's. I don't know. I don't know the answer. It should be in the computer how many of them, but it's not the conversion. It's the association. You have a telogen effluvium 3 months. And the physician wrote down inside the electronic or the chart also androgenetic alopecia because of the pattern he shows in the patient. But that's a good point. I don't know how it's the total population. How much is the association? I don't. It is easy to pick up. But I didn't get it. Thank you for. I will. Thank you for the question.
Very good. Thank you.
Thank you.
Frank, could you help me with the computer sometimes? So before we go to poster break, let's have a short poster break in seconds. And